So this is Jen. I think you're in the future of VPS and data-driven QI.
Is this on? Okay. So our discussion centered around the question of what does VPS need to do in the future to meet the needs of critical care? And the wish list, if you will, centered around about 3 different themes. I'll mention the themes first and then go into a little bit more detail about the discussion. One was theme of the entire meeting, automated and or increased efficiency of data collection, a theme around certain data elements being added, and a theme around transparency. So I'm going to start with the theme around certain data elements being added for a couple of different reasons. One centered around illness severity adding renal elements, hem-onc elements, adding PLOD2 score, adding labs, so getting to a little bit more granularity of data about the patients. And then there were additional data elements around process measures, ways to better interpret the benchmarking measures, workforce staffing data in order to add those to, again, the benchmarking and QI view of the data. The 2 major themes that took up most of the discussion were the themes of the automated data collection and transparency. So in terms of the data collection, there was a lot of discussion around the balance of automated data collection versus what VPS is now with high quality data that has been curated and over the years. So where we sort of, I don't know that we came to any solutions, but where we got to was that perhaps there probably are some data elements that are able to be collected in an automated way that maintains the quality of data that is desired for specifically quality improvement in clinical research from VPS. But there probably right now at least are some data elements that would continue to need a clinician to interpret things like diagnoses and even dates and times of admission to the ICU, and what does that mean, for instance. The other point that was made was that from Mike Dean's experience, mentioning that automated data collection itself is also not free and not necessarily cheap, and does require ongoing maintenance and ongoing maintenance costs above and beyond the initial setup. And so the other sort of major discussion point that came up that we ended our discussion on was the idea of transparency. And by transparency, it was meant identifying sites within the network in order to catalyze collaborative QI efforts. So if you knew who the high performers are, that you could reach out and get ideas. How are you doing this? If you could get together and devise multi-center QI projects, you would be able to get data back and knowing which centers were participating in your project. The examples given were the PC4 Collaborative, STS, et cetera. And so certainly a lot of discussions around would hospitals do this, and went through some of the history of VPS. And where we came up to was maybe now. We're in a different landscape. Certainly there are other examples out there. And then the example specifically of the PC4 Collaborative starting with a specific collaborative QI project around the early extubation after cardiac surgery. And if that is a way to start to do this in a stepwise fashion. And anything I missed? Questions, comments, complaints go to Randall?
So Jen, I'm not familiar with the PC4 effort in that way. Was it an opt-in, I would assume?
Somebody, I'm on cardiac. Is somebody more familiar with PC4?
No, that's a pre-PC4 formation project, but now PC4 there's no opt-in. Everybody gets to see their.
But for a specific project, for something like early extubation, is that that's an opt-in for? Okay.
Of willing, coalition
sure.
Of willing,
And then shared results amongst those who opted in. Yeah. Okay. Super.
That was great, Jen. Thanks so much. I know it didn't end up being the final focus of discussion, but I find the idea of having that staffing data available for leadership discussions to be very, very compelling. If we can go and say, hey, our ICU is lacking in length of stay or mechanical ventilation, et cetera, and it specifically happens when we are understaffed, and this is how we are understaffed compared to our peers, I mean, that could be incredibly compelling to the C-level folks. So if there is a way to include that as a quality metric, that could drive a lot of change.
Yeah. And that certainly stayed on the list. And I think part of not surprisingly, is this balance of how to collect the data, where would you find the data, versus other priorities of data collection and the cost of all of the data collection.
So what's the quality project we could all agree on and move forward?
What's the best nurse staffing ratio, or what's the
quality project? If
PC4
started that way, part of what I'm trying to I'm wondering is, did PC4 start that way because there's less heterogeneity in thought process and approach, and early extubation of cardiac kids seems like, oh yeah, I mean everybody wants that, right? I'm not sure we could. Or maybe that's where we need to change our mindset and drive what is that quality project that we could utilize VPS to drive forward.
I was gonna say I'm going to turn this to the room. We've got a room full of people. What is that first collaborative QI project? Heard early event liberation.
Extubate the kids.
Early extubation. There we go. Done. And Nelson's in charge.
You got your answer, Tim.
Yeah.
But we need to do it in an organized way. Mm-hmm. One thing that the data may be able to help, we've been talking about this, Colin, we've been talking about that, is the whole how do you adjust for the kids, right? Because everybody can be like, oh yeah, my kids are intubated longer because my kids are sicker. I don't think that the severity of illness scores from day one really tell you anything that's meaningful to predict the length of mechanical ventilation. And there's many other variables that are there, including time of the day, time of the week, and all these other things that we should be paying attention to. What modes of ventilation you're extubating those kids to, because if you're extubating a kid early, but then they spend a week on maximum BiPAP settings, probably not ideal, right? So I think that there's a lot of, that's where all the vent liberation work and the guidelines come through, and I think it's just a question of organizing ourselves, get the right severity of illness adjusted, expect the length of mechanical ventilation, find those high performers, and then learn from them, and then try to establish some standardized bundles for everybody to follow. I think Robbie has.
Can I just make a comment? I mean, it could be duration of mechanical ventilation or early extubation, but find the cohort that you're going to agree on. So you're going to exclude patients who are difficult to extubate, or they have other reasons not to be extubated, but pick a cohort and go with that one cohort.
How do we know who has what disease?
I'll just chime into what you said, Nelson, is that there is, some ongoing work, right? There's a policey group through Sammer and Jeremy that are doing this with Near for Kids as an example. But I think Jeremy actually just sent an email, like 3/4 of the sites are VPS sites that are a part of that group that have already signed on for this initial piece. So it could be a good test case that if we can, harmonize in those sites at least the data collection, it could work.
Well, and could VPS be leveraged as a way to translate single center QI project to multi-center, where much of the data is already collected, and utilize what's there?
So question for Randall: if 3/4 of the sites are VPS sites, would VPS support 1/4 of the sites using the VPS backbone to collect data so that it is standardized across 100% of the sites?
prorated rate.
I was just going to say getting back to this conversation about that particular QI project. It strikes me that you're not capturing the patients who may have been intubated in one unit that didn't get intubated in another unit. And I think a little bit about Ascend and how Ryan Barbaro is trying to capture patients with, Martha, correct me if I'm saying this wrong, but patients who have ARDS and then some go on to ECMO and others don't. And how do you make that decision, and what are the long-term outcomes? So I think it's nuanced. So
more seriously, answer that question. All of that data structure obviously costs money, but B, if you're not a VPS site, you're going to take training. To bring a VPS site on board takes us 6 months to a year. And half of that time is the lawyers, but the other half of the time is training the data aggregators. That would seriously impair quality if we just sort of said, I would be willing to have short-term VPS memberships, but if you want to maintain a data quality, you're still going to have to spend a good deal of time training people. The nice thing about VPS is if you can do it with data we're already collecting, there's nothing. You just get it. Doesn't cost anything. So those are questions to be answered, but also I'll be happy to welcome those 25% who aren't members to join. Let me ask. I want to be able to see the room for this one. I guess I'm going to ask the VPS members one more time to raise your hands. Now I want you to keep your hand up if you are willing to participate, if you would continue participating if we published in our reports the name of your hospital. Not you. No, the next, keep your hands up. Okay, that looks good. We're all willing to be transparent, and we all would like to be, I bet. Keep your hands up. How many of your hospitals will allow you to do that? They're dropping rapidly.
Randall, to be clear, when you say publish, you mean like on like the VPS annual?
Yeah, sorry, internally publish, not world publish. Yeah, just make us transparent amongst ourselves. And how many of your hospitals would be willing to play in that? I mean, we're good. Yeah, this is a wavering.
Things have changed in the last
10
years.
Well, I think we just made a little decision that we'll be talking to all of our members about whether they are willing to share their data within VPS. I think we have a track record. We haven't spilled any PHI ever. So we haven't got in trouble that way. We can maintain confidentiality, I think. I will say that, however, it is possible that a member who sees these data uses it for advertising or publicly. I mean, that'll be something contractually people will have to agree to keep it within the collaborative. But
really mean marketing.
Yes. So I think we'll be pushing in that direction. I didn't know if you were joining VPS or not.
I'm just keeping my hand up. Okay, you put your hand up.
I'm sure that, how many of you who answered yes are in Phys? If you're in Phys, you are sharing your data, the hospital name with the other Phys sites. They see it every month, every year, whatever. And I'm sure that many of you are part of probably 20, 30, 100 different registries where there is transparency within the registry about your site. So if you think that your hospital won't do it, try to keep an open mind.
Excellent. Tel, do you have a designated presenter for where the CDS systems? That's right. What was the Department of Transportation? The Secretary of Transportation for the State of the Union? Well, this year